Does everyone here mark their cavities for breast conservation? Yes, 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 yes. Yeah, most people do. I've worked in my career with people who thought that it was not important at all. So I think it's encouraging that most people here do think it's important, and I think as we get more into the era of partial breast radiation, that it becomes more important. Um, is so we all or most mark the cavity. Are you using something other than clips to mark the cavity? Just a show of hands. Okay, so most are using clips to mark the cavity. So we have ability to influence here. Do people here, because I find this interesting, know whether your radiation oncologists are delivering whole breast radiation or partial breast? Are you aware? Is this a discussion, or do they just do whatever they want? Are people aware of what their radoncs are delivering? Yes, 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 yes. Is there a discussion at tumor board, or you just sort of know what their habits are? So is that afterwards or before? Okay. Others? You communicate. That is awesome. It's alive and well. Awesome, awesome, awesome. Okay. So others tumor board discussions over every case or yes? Tumor board. Okay, so you read my mind on the next question. Is anyone applying sound or Encima or ASCO guidelines routinely? Or has anyone come and what's the agreement at your hospital? Is it one-offs or is there a standard? I think that's a reasonable approach. And is it all comers or is it essentially luminal A? Okay, so triple negatives and okay. Someone else in this area raise their hand. Yes, sir. What what's your policy? So one of our answers was they're going conservative, but across the board they're applying it to 65 and older. But essentially, luminal A, you're hormone receptor positive, HER2 negative. Another was discussed at tumor board. What are you all doing, Jennifer?
We are applying it selectively to women over 60 with hormone positive, HER2 negative breast cancer with the clinically negative axilla. But for our program in our negotiations with radiation oncology, we are at a comfort level to do partial breast radiation for all patients using sound to manage the axilla. That's that's a conflict.
So that's been a bit of a trade-off. Is that what you're finding, or was your agreement still they'll do partial breast in that situation?
I'm not sure what to do with that.
Okay. So the answer is Radonk is confused, which I could answer that about me any given day. Shauna, what do you all do at your institution?
We're probably doing.
You can, that will lower.
Oh, will it? Do I turn this?
You turn this and it goes,
Thank you, Susan. We're probably doing very similar to what Jennifer's doing. Probably more on a case by case basis. Um, but uh, not doing a sentinel node biopsy does not preclude APBI.
okay.
So we're on a case by case basis also, and when we're looking at the low risk women, low risk tumors, we will omit. We're starting to omit sentinel node and still do APBI, but that's still on a very case by case.
So when we say case by case, does that mean at tumor board you review every breast cancer prospectively? I mean, are your tumor boards 4 hours long? No. But you review every case. You don't.
I do.
You do.
Quickly, efficiently, and appropriately, but yes, yeah. We have the
Of
ability
course,
to, yeah.
it's efficient,
I
of
mean,
course.
no, I mean,
It's sunny, it has to be
hospital,
efficient.
so it's not a million patients every week with a new
And
diet.
you review can we just take the mic out maybe and just pass the mic?
So I'm in a program where the policy is that every patient's presented at tumor board before and after surgery. We're able to streamline the pre-op patients for patients who clinically there was just no indication for anything other than surgery. So DCAS and these luminal light cancers in women over 50. But we do present every patient. We group them so that, if we have several women who have very similar tumors, we can present the case and then say management of like the prior case. Um, it's just unfortunately, it's a principle that, I don't know, it's unfortunate, but it's dyed in the wool of the program. It's a signature of the program. So we're just not getting away from that. I would say for one area where our radiation oncologists are comfortable with APBI is in the upper outer quadrant. So in the upper outer quadrant, which is where most breast cancers are, your partial breast radiation is probably to get that lower axilla with the tangents that they talk about from whole breast. So that's been a little successful story for us for trying to incorporate sound and incorporate partial breast radiation. So
I have to say it's an exciting time to be in breast surgery, but it is confusing with all these changes, and it really is a team sport. So we can't just make a decision on our own.
right.
It has to be the entire team. And then the final question before we really get into our discussion here is for those who are using Veraform, do you have any feedback from patients? Or patients upset about having this put in when you're discussing it with them? Is there any feedback from the patients? Any users here? Veraform users? Yes. So patients are fine with it. I was speaking to a physician yesterday who does not use Veraform, and she said she does not use it because her thought was all patients would object to having something that does not dissolve. I've been using Veraform 6, 7 years, and I can tell you I've never had one patient say, "Oh, I don't want that because it doesn't dissolve." Have any of you?
Yeah, so I had a practice where I had a lot of the people that even thought that their biopsy clips were poisoning them. So I had Veriform in my exam room and I would tell them what it was, why I wanted to use it, and I would put it in their hand and I would let them show that, and that just eliminated all the problems. So it sort of weeded out those ones that were going to worry about it. Most people, when you tell them the benefit, they were like, yeah, I want that.
Yeah, so I agree with you. I think show and tell is always helpful with patients. So now that we've been discussing this, I'd like to introduce my esteemed panel. Again, proud to call all of you colleagues and friends. Dr. Sunny Mitchell, who is in Montefiore in Nyack, beautiful Nyack in New York. If no one's been there, go visit. It's on the water or close to the water, right? It's over some bridge, and I live there. I know I'm lost when I go over a second bridge, and I'm like, oh my God, I'm not supposed to be on this side of the bridge, but it is beautiful. Dr. Patricia Clark, who has recently moved to Parkview as chief of, did I get it right? Not so. Deb, you confused me. I saw you earlier and thought Parkland, but Parkview. Dr. Willie, who is, as many of you may or may not know, the grand dame of our society here. So the power color red is appropriate. Dr. Willie is at Innova, in Innova. See, I got a lesson in how to say things this morning. And Dr. Jennifer Goss is in beautiful Rhode Island that I get to drive through
it's
on my drive.
through state.
It is a drive-through state.
At least a
It is
small.
wait, I just heard this. It is the second smallest state in our country. I don't remember which the
Delaware?
first. Delaware might be the first, but it is the second smallest state. Okay. So much of what we do is de-escalating care. We're de-escalating surgery. We're de-escalating systemic treatment. We're de-escalating, hopefully, radiation treatment. They are the last ones to come along, but we're going to get them there. So Astro came out with the following recommendations several years ago that are a little slow on the uptake. I mean, but who are we as surgeons to speak to slow uptake at times? So, partial breast radiation is strongly, not a little bit, but strongly recommended for early stage node negative, favorable tumor characteristics, grade 1 to 2, hormone receptor positive, HER2 negative, age 40 and older, that gets younger every day. It is conditionally recommended in, and it's interesting that it's conditionally, it's not, oh, it's contraindicated. It's conditionally recommended in those with a higher recurrence risk, that being grade 3, ER negative, and larger tumor size. Take home points, there's a lot of points here, but the main thing is there is no significant difference between partial breast and whole breast radiation, no matter how we look at it. It's one of these things. We can look at it several different ways and it never changes. There's no significant difference. So, if anything, please go back to your radiation oncology colleagues with the message of, why are we not doing this? And if you're doing this, if they're doing partial breast, it's, why are we not doing it more often? And everything is about standardization and protocols. So I strongly encourage everyone to go back, bring that message back to your home institutions about standardizing in protocols. So maybe every single patient, we don't need to guess, because as we're sitting there in front of the patient, it's nice to know what the radiation oncologist is going to tell them so that we can have that discussion up front, not, oh, wait to see what the rad onc says. Is it going to be a 5-day treatment? Is it going to be a 6-week treatment? Have that discussion ahead of time. But with no further delay, I'd love to introduce Dr. Sunny Mitchell.
Good morning. Thank you so much. Nice to see everybody here this morning. What I would like to talk about is actual placement of the variform in the setting of a pretty straightforward lumpectomy. So we'll go through an animation that has a lumpectomy via a periareolar incision. We'll demonstrate several different options of how to place the variform in the actual tumor bed itself, not the entire surgical site. And then we'll also take a look at an animation that goes through a lumpectomy. Once again, we chose a periareolar incision just because it seems to be the workhorse incision for a lot of us. In that second animation, we will incorporate tissue mobilization or tissue transfer mobilization in both the superficial and the posterior plane, with the demonstration of marking the tumor bed as well at the same time. Uh, so let me go through this for you now. This is a animation. It's just a couple of minutes long of placing variform in the setting of a lumpectomy performed through periareolar incision. So here's the breast. We made the periareolar incision, mobilized superficially to have a workspace. Perform the lumpectomy, remove that tissue. We take out the variform. Typically what I do is tie a knot at the end of the tail and then trim the tail. And in this instance, we're going to use a helical type of a pattern, marking posteriorly all of the walls, and then the most proximal wall, closing it with multiple interrupted 3O vicryl. So that is a technique of marking, which is usable in many situations, and that involves putting a knot in at the end of the tail to hold that variform in place. There's also a cool technique that Dr. Willie will talk to us about, which I plan on using from here on out. In a lot of cases, that involves not actually putting a knot at the tail to hold that in place. And I'll show the animation of it. Did you want to describe it first for us?
Basically, I put an anchor stitch. I put a variform anchor stitch, maybe throws 2 knots or 2 throws into it. I put a snap on the end of the long end, and I spiral it around in 2 different planes. So you want to get the anterior and the posterior so that you're really encompassing where the tumor was. And I got tired of tying knots and having all the variform material there. So I just tie it back to itself. I plan it so that I tie it back to itself. And you're not really approximating the cavity with the variform. You're just trying to delineate the cavity with the variform. So I just don't like to futz with all the knots and stuff. So I use that technique to just make it faster for me. And but you have to be true to where the tumor is. If you have a tumor excision that's rather large or the tumor is very eccentric, you really want to mark where the tumor is, and you're gonna know that when you get your specimen radiograph. So, it's all a we know best where that tumor was, and what we are marking is what we're communicating to our radiation oncologists.
So let's take a look at some additional marking patterns that we can utilize. This would be an oval or circular continuous form on the lateral walls of your tumor bed. That works very, very well. Also, you can mark the tumor bed the same way with a posterior marking and then an anterior or superficial marking at the tumor bed. Another, which is great for just pretty small lesions, is just one loop actually, right at the tumor bed site itself. If your lesion is really pretty small and the shape, size, density of the actual tissue itself lends that is the best way to go. So on this image, we have a mammogram, thanks to Dr. Beth Dupree, of a postoperative patient who's had the variform placed in the actual tumor bed itself. I believe this was one of her first cases, and what she did is she did a loop at the posterior aspect of the tumor bed, ran the variform up to the anterior aspect, and then did another loop so that she was perfectly delineating the actual tumor bed itself. You can see what it looks like on the mammogram. And then, thanks to Dr. Bayer, one of the prior presidents of Astro, for giving us these images. This is a day 0 and then day 48. Again, I think this was one of the first, if not the first, patients that they did, demonstrating what the variform looks like initially in that first picture. With you can see the seroma cavity, which we expect in the immediate day or 2 or so of a lumpectomy site, and then the variform itself without any seroma around it. Thanks to Dr. Patricia Clark for this setup for how we will be placing variform at the time of doing the lumpectomy, as well as just simple, straightforward tissue mobilization. We're developing in the superficial plane. We're developing in the posterior plane to help reapproximate that surrounding breast tissue to eliminate the defect that we create. So in this first image, we can see that superficial plane just directly through Cooper's ligaments. The depth of that flap varies patient to patient, as we know. And then the second image is just a really lovely depiction of superficial plane, posterior plane, and how sometimes once we remove that specimen or have that lumpectomy defect, the side walls are, we're not able to mobilize them together. So we just mobilize superficial and posterior and bring those side walls together. So let's go through a quick animation on this as well. So periareolar incision, develop the superficial plane to give us a working space, do the lumpectomy. And in this instance, we're putting in a variform on each of the medial and lateral wall of the tumor bed itself. And then we just take each case into on an individual basis. How dense or fatty is the breast tissue? Do we need to mobilize further to be able to close a defect? We see here that we don't have room, so that we perform mobilization in the posterior plane as well as the anterior superficial plane. And then the same thing on the other side wall that allows us to reapproximate those walls. And then close with multiple 3-ovicral, of course. And then we have a couple of other examples as well. You can use any pattern that you desire. This would be an example of a helical pattern or a spiral. And then also a cool technique, I'm going to show how she does it, is actually forming, creating a loop to fit your tumor bed exactly, tying that off, and then placing it at the exact site that you want it to be, and doing a few pointed 3/0 vicryl sutures to tack that in place. Okay. And that technique, the last placement of the Veriform that I just went over, is something that Dr. Tony Storm is doing. She finds that it works very, very well with her. I think she uses a rich or a baby rich, whatever size seems to work for her to be able to facilitate closing that, creating that loop. And that is all I have to present this morning. Thank you so much.
I often find with stuff like this that it's so helpful to see that demonstration and see that video. I remember the first time that I was introduced to this product, I just kept saying, well, how do I use it? How do I use it? What do I do? But I think the nice thing about it is there's really not a wrong way to use it, and I have my set ways to use it, and then it varies somewhat patient to patient and how deep the tumor is or how superficial the tumor is. But thank you, Dr. Mitchell. Dr. Wonderful Patricia Clark will help guide us through the next section.
I'm going to talk about just advanced breast conserving techniques, cavity marking, essentially the level 2 oncoplastics. So we've been doing this since about 1990s now. And one of the challenges for doing breast reduction, doing mastopexy, is we move this tissue all around. So we've really distorted the lumpectomy bed, and that can be quite a challenge to our radiation oncologists. And you can see when we first started doing this, we looked and we just sort of straight modified these things. If the tumor was in a location that would normally come out in a standard reduction or mastopexy, that's what we did. Now we do quite a bit more than that. Um, as you can see on this, one of the problems with level 2 oncoplasty with the nipple areola complex, we're often mobilizing that, rotating it out of the lumpectomy bed. It'll form one wall of our lumpectomy bed. So for our radiation oncologists, when we go into partial breast irradiation, etc., we really need to consider this. We have multiple different pedicles that we can use for anyway, multiple different pedicles that we can move the nipple areola complex on. The pedicle can be based from any direction: superior, inferior, medial, lateral. What I'm going to show you is just a superior based pedicle. And I think of Veriform as my aim here spot for the radiation oncologist. With the Veriform, if we've really marked exactly where that tumor bed was, if there is a possibility of boosting our patients, we've given them the opportunity. If there's an opportunity even for APVI, which on some of these pedicles, we can actually do that. So I'm going to start with just this superior pedicle. This is a great pattern for somebody with an inferior pole tumor. Those are very difficult. We get bird beef deformities. So we're going to start out here with the markings. So first thing we do is place the WISE pattern markings, deepithelialize the superior pedicle for the nipple areola complex here. We will raise that. I can access take my lumpectomy, access the bottom of this resection. You can do this two ways. A lot of times I will actually take the tumor as one specimen and then complete the rest of the WISE pattern. A lot of surgeons will take the entire section that they're taking on WISE pattern at the same time. So we move on here, and I've got these nice medial and lateral pillars here that I can place the WISE pattern, place my Veriform. One of the things I really wanted to show on this animation was when we're marking this posterior plane, I know where that tumor was. I know how wide this should be. We've raised right there. I showed you where we've raised the medial and lateral pedicle, we're going to move those together, and we'll see that that posterior plane is now underlying my medial and lateral. And this was just tailor tacking the wound together to make sure that everything fits. I don't have undue tension. I check the whole thing, come back. So after I've tailor tacked all this together, now I open it up. And here, from deep to superficial, I pexy the medial and lateral pillars together, and that's what's going to close all the dead space. And you can see how the posterior veriform is marking a much wider tumor bed than if I had just put some clips in this medial lateral. So we close this, close the incisions, and here we're done. So I also like to place a veriform up superiorly. You can use this marker however you want to mark that cavity. You're showing the radiation oncologist, aim here. So you place this however it makes sense for you. And then I'm going to finish up with this is a simulation of one of my patients that I did just a standard lumpectomy in, periareolar incision, and I had put clips in, and then I put the veriform in because we do a lot of APBI over the veriform, and you can see the difference with the little green clips, how big this lumpectomy cavity was. But with the veriform, I got a lot more accurate marking of this lumpectomy cavity. So that was sort of the sweet spot for me with it.
Next is Dr. Goss, who is our former program chair.
So thank you everyone again for being here this early. So we've heard about why it's important to mark your cavity. And what I just want to review with you a little bit is the study we did at our program trying to evaluate, do you use the clips that you can just flip up? Maybe you already have the clips on your field because you're using them for your surgery. So can you just use the clips, put 6 in there and mark your cavity? Is that going to work well? Or is this cavity marker a better strategy? And so the way we executed this study is we had 6 expert radiation oncologists make a treatment plan for 10 sequential patients during this time period. And then we measured 3 metrics comparing volume, the DICE coefficient, which is how similar is one treatment plan to another, and then the center of mass, which would be, as we were trying to target the tumor, how accurate was that? And so we used statistics to evaluate those, and we chose 2 groups of patients. We chose your standard lumpectomy patient, getting oncoplastic surgery to close the cavity, so to speak. But then we took the sort of more extreme oncoplastic patient where you're doing a breast reduction with your lumpectomy and compared that group. And we presented this data at ASTRO, I think, 2 years ago. Really, to not much surprise, every which way we measured the volume or the DICE coefficient, the comparability to the plans, or the center of mass, the monofilament, the FM, the filament marker, outperformed the clips. And the difference was statistically significant. When we turned to oncoplastic cavity marking, we saw the same thing. And I just want to bring your eyes down to the average center of mass difference, because if we want to take the benefits of partial breast radiation, you can see that when the experts were planning making their treatment plan, they had a centimeter of variability when they were using clips to try to target their cavity. And that was significantly reduced when we had the monofilament cavity marker. Even in this setting where we had an oncoplastic reduction with all of those other surrounding inflammatory changes, that they kind of have to put the blinders on their eyes while they try not to look at these inflammatory changes that they want to target and look just at our cavity marker. I'm just going to flip back to the last slide because it was similar even for a lumpectomy. That last center of mass deviation is the easiest one for me to conceptualize, and saying that the radiation oncologist had a centimeter when we gave them clips and half that when we gave them the monofilament cavity marker. So that we use this throughout our 3 institutions where we do surgery. And here's just a last demonstration of how well the cavity marker in that image can mark out the lumpectomy cavity and try to separate out separate inflammatory changes that happen when you mobilize the breast off the pectoralis fascia, like you saw in the animation. Um, so I won't belabor that. I'm going to switch now to the Europa trial. I don't think we heard about that too much yesterday. I was there. But this, as we all heard about this coming back home from San Antonio from our folks who attended the meeting, and I've heard it talked about at Tomb Board a great deal. But it was fun preparing this for you to just kind of look at some of the micro details of the trial, which is available primarily in abstract. So this again is looking at a big patient population for us, our women over 70. And as I say here, it was a randomized phase 3 controlled trial. It's a nice trial because it's of a short duration, so they were able to accrue. There was great interest in accruing patients to the trial. And then in this trial, they were randomized to exclusively, as the banner says, exclusively radiation or endocrine therapy, with just about 350 patients in either arm. As we know, they were our more favorable tumor type, but you only had to be 10% to be hormone receptor positive, greater than 10% estrogen receptor expression, of course, HER2 negative, and then the Ki-67 was under 20%. We already said the women were over 70. Grade 1 to 2 for the very small cancers under 10 millimeters, but if it was T1C, it was grade 1 to 2. Did I say any grade for T1A? And then it was a 1-to-1 randomization. And this time we were really focusing on quality of life and expecting to see breast tumor recurrence rates. But that's going to be more forthcoming, right? Because we're at 2 years of follow-up. So this interim analysis was just of 100 patients in each arm. So that is a small number of patients that we're making big decisions on. And so if we look at these several different tools they used to measure health-related quality of life, and this table is decrement over time, but they did see a statistically significant difference in the decrement of health related quality of life metrics that were used in the trial to the radiation arm versus the endocrine therapy arm. So this has led us in our program to think much more seriously about radiation therapy for particularly the T1AB tumors, where the benefit of endocrine therapy over time is uncertain. So looking at these treatment specifics, which is treatment-related adverse events. So I'm not sure how I got my acronym up there, a little alphabet soup for you. I apologize. But those are treatment-related adverse events. And so you can see that there were fewer adverse events in the radiation therapy group and more adverse events, those ones that we hear when we see our patients in follow-up for patients on endocrine therapy. And so it's just intuitive to know that if we can get the radiation therapy done within 5 to 10 days, we can listen to those adverse events and help them manage them, but they don't need to continue to experience those adverse events for 5 years. And then they also cited that in the endocrine therapy group, at least a quarter of patients switched medications and 1/8 of patients discontinued their medication. So that always feels like a challenge when you've sort of nursed them through the transition, but now you've fallen outside of the endocrine therapy, the radiation therapy window. To summarize, the results at 2 years, we saw a more significant decline in healthcare quality of life and functional symptom scales for the patients on endocrine therapy as compared to radiation therapy. There were no in-breast tumor recurrence, local recurrence, or distant metastases events. There were contralateral events that were similar, and there were death events in both arms, which were noted to be unrelated to breast cancer. So, in conclusion, it sounds like we've covered some of these topics, which is, should you mark your cavity? But how are you going to mark your cavity? Um, one of the things I've looked at in my career is breast cancer survivorship. And so as we try to de-escalate care and improve survivorship, how are we ensuring that our treatment toxicity, which is surgery, is well tolerated by patients and has the least impact that's appropriate to keep them disease-free for the rest of their life? So in conclusion, that brings me to the end. I can answer any questions if people want to talk, or turn the mic over to Dr. Willie.
So we started using Veriform in 2019, and we did it kind of as a pilot project with just two surgeons. We brought the product in, and one of my residents wrote this up as a quality improvement project for our institution. So this is about a 2-year period, and we just had two surgeons. So we had 104 patients that we placed Veriform in. You can see the average age was 62 and 98% of the patients had a lumpectomy. And we haven't talked about it, but there is an indication for using this in a mastectomy. I'll talk about it a little bit later. 82% of the patients received radiation, and that's a question I've gotten a lot is, do I put a Veriform in all the time, or do I try to predict if the patient's going to get radiation? And I put a Veriform in all the time when I'm doing a lumpectomy, regardless of the patient's age, because I can't go back and put it in. And our radiation oncologist requested that, in fact, every tumor board we have, they say, well, we assume you're going to put a Veriform in. And we're like, yeah, we always put a Veriform in. We had 2 complications of hematomas, which is 2% of the 104 patients and was not product related. You can see here what our operations were. Most of the patients had a level 1 oncoplastic reconstruction, but we do use this in our level 2 patients, and we work with our plastic surgeons as to how we place it, and you saw some great conventions. And again, I'll make the point that you're marking the tumor bed. You're not marking the whole exposed surface. So if your tumor bed is 1 centimeter in a big oncoplastic resection, you really want to try to refine where that area is and communicate that to your radiation oncologist. And then the level 3 would be those patients that I would say had extenuating circumstances for most of the time for local recurrences. So my resident did a survey of our radiation oncologists, and I thought this was kind of interesting because we had just started using this. We kind of rolled it out, and we just didn't know what the radiation oncologists would think about it. But we worked on it as a team, and they said that they found the Veriform most helpful for the deeper lumpectomies. And you have to kind of get in a radiation oncologist's mind and say, how are they gonna pick what they're gonna draw those little circles around? And if you don't have a marker in there, they're gonna draw those circles around anything that looks like it's postoperative change. And if you have a tumor that's in the upper outer quadrant and you've tunneled from the axilla, they're gonna radiate that whole area, or they're gonna boost that whole area because they really don't know. I mean, they could try to compare where the tumor was by mammogram, but they're doing their planning by CT, and it doesn't really translate perfectly. So they liked it when we marked the deeper lumpectomies. And of course, they liked it most when they were doing PBI, and I'll show you another study about that. Um, and their advice to us was cover the cavity as much as possible. So again, all those conventions that you saw where you spiral it around, you really want to make that three-dimensional for them so that when they're doing their planning, they're going to get the whole circumference around the lumpectomy cavity. And then I thought this was really cute. They said, ensure that the tails don't poke into the non-target breast tissue because they're really looking at this and they're really using it to map everything out. And if you leave a long tail and it's sticking out into tissue that isn't even close to where the tumor was, they're going to radiate it because they think we're trying to tell them something about that cavity. So you really want to try to keep it tight and precise. So basically, our radiation oncologist felt that either they strongly agreed or they agreed that it is useful in marking the tumor bed, that it simplifies their radiation planning, and we like to simplify our colleagues' life most of the time, and that it enhanced the target coverage and reduced exposure of normal tissue to radiation. So I think that is also a goal that we have for our patients is I do think we complain about our radiation oncologists that they're one of the few specialties that aren't really de-escalating as much as we are. But in the form of this, we can help them de-escalate their treatment. So then we had this was an abstract that was just presented at Astro. And we are doing more and more partial breast irradiation. Um, I personally think it's a great technique for the patients. They only have to have 5 days. They don't get nearly as much toxicity, and I don't care what the radiation oncologists say. We know we're seeing these patients 5 years down the road, 10 years down the road, and they have toxicity from their radiation that is permanent. I always tell the patients when they're complaining about these side effects from the radiation, you know, you have these side effects because radiation works. It killed the cancer cells and maybe also affected your normal tissues. So we see that happen, and you can either have the large breast that's swollen or the small breast that's contracted. So APBI, I think, is a great tool for the patients. At our institution, they give 3,000 centigrade in 5 fractions. And this was a retrospective review of our patients that were either stage 0, DCIS, or stage 1. We had a total of 73 patients, not a huge cohort, but still looking at whether the radiation target volume could be decreased. Our follow-up at the time of the publication of this abstract was 23 months, so kind of similar to the Europa trial for their first 100 patients. And looking at ASTRO guidelines was, the patients were acceptable per the ASTRO guidelines or cautionary. And you can see that most of the time we follow very closely to the ASTRO guidelines, but for various reasons, sometimes either because of distance or comorbidities or whatever, we try to do APBI in patients that might be a little bit more cautionary. And the hypothesis was that the combination of using breath hold technique, deep inspiration breath hold, and a filament marker, that the radiation oncologist could really tighten their partial breast radiation field and decrease the targeted volume. And just so you can talk a little radiation oncologies. The CTV is what they talk about a lot, the clinical target volume. And basically, it's just kind of a concept. It's just like when we go in to do a lumpectomy, we're trying to use a mammogram and an ultrasound and palpation to, in our mind, figure out what that three-dimensional resection specimen is going to look like, or how it's going to be shaped. They're looking at the specimen, and they're looking at the pathology and the margin width, and they're trying to come up with how much of that breast tissue needs to be radiated. That's the clinical target volume. And then they kind of go, the tradition is that they go 10 millimeters outside of the clinical target volume to get the planned target volume. That's what the convention is. So our radiation oncologists used deep inspiration breath hold and the filament marker to see if they could tighten that up and only radiate 5 millimeters for the planned target volume. And you can see that with the results, our local control was 100%. We didn't have any local control issues. And again, we're only at 23 months. But typically, if you're going to have a real recurrence of that tumor, you're going to see it at least within the first 5 years and oftentimes within the first 2 years. But I think this is remarkable that the planned target volume was reduced by more than 80%. And if you think about that in regards to what your specimen size is for a lumpectomy specimen, you know, most of the time we're probably resecting somewhere between 50 to 80 grams, something like that. So the amount of breast tissue that is being spared radiation is quite significant. And of course, we're going to follow these patients up and make sure that our local control is good. But it's just the thought that our radiation oncologists were really trying to de-escalate their therapy and not compromise cancer control. So now at Inova, we have 9 surgeons who are using Veriform at 5 hospitals. I say 9 surgeons plus because we have 9 surgeons that are on our staff, but we also have other surgeons. In fact, Dr. Akbari, who did one of the initial placements, and we did that first study together. We have several other surgeons who use Veriform in our institution. We've placed more than 3,000 Veriforms in about 5.5 years. And I would say it was really a team approach that has driven this. And our radiation oncologists hope that we put a Veriform in every single patient. And I want to show you some mammograms. How are we doing for time? We're good? Okay. I want to show you some mammograms to show kind of the vagaries of clip placement versus Veriform places versus no placement. Although I'm not showing you any of no placement. And I will say I encounter people all the time still. I was teaching an oncoplastic course yesterday, and one of the surgeons said he doesn't put any clips in. He doesn't mark the cavity in any way. I don't know how he communicates with his radiation oncologist, but in any event, this is a close-up of the right, CC and right MLO, and I'll see if I can you can see here, and this is a little bit, I think, what, Sunny who no, Patricia, you were talking about where you put a Veriform in, but you also place clips. But I wanna point out that this is a case where this patient has clips all over her breast, and they don't necessarily signify that that's where her cancer was. She also has a bunch of biopsy clips in her breasts. You know, in this day and age, women are just collecting these clips in their breasts, and they just become more and more numerous. So we have to communicate. She even has one up in her axilla. So if you put a Veriform in and you're using clips at any point in time with your lumpectomy, or if you're doing I see it more commonly in oncoplastic surgery, you can use clips and not have to worry that you're gonna confuse your radiation oncologist and have them say, "Okay, well, there's a clip up here. Do I need to boost that? And do I where do I target my radiation?" This is an oncoplastic case where there was no Veriform placed, but look at all those clips. How would a radiation oncologist even know where the tumor was to begin with other than looking at their preoperative mammogram? And of course, we all know that when you do an oncoplastic resection, you're rearranging the tissue significantly, as Patricia said. I had a case one time where the tumor was originally in the upper inner quadrant, but it ended up after an oncoplastic reconstruction in the upper outer quadrant. She never would have gotten radiation in the right place if we hadn't marked the cavity. So I make a plea, especially during oncoplastic surgery, use one of the conventions that you saw in the videos. You know, a simple lumpectomy, you can see how I just place it, I place it deep, I spiral it around. You do have to be careful not to have your knot be too superficial. And that's why I started doing the way that I do it, so that I'm diving that last knot deeper in the breast tissue. Because I do have a couple patients that I were early in my experience, and every time they come in, I say, "Oh, yeah, I can still feel that little knot that's superficial." So you don't want to leave that superficial. If you do want to mark more superficially, I do that by just going almost in the anterior flap, just taking it straight through that, and then diving it deep again so that the knot is deep. And then this last photo, I think you can see this is a rib and that is a rib. This is a patient that had a chest wall recurrence um, after a mastectomy, and she had not gotten radiation after the mastectomy. And I knew she was going to get radiation. She had muscle involvement, had taken muscle down to her rib. And I wanted to be sure that the radiation oncologist would know exactly where that boost needed to be. So you can use Veriform in any place where you think radiation is going to be necessary, and is not necessarily where you think it's going to be the target. The radiation oncologists don't know where the tumor was necessarily when you've done a mastectomy. So if you know somebody is going to need radiation after a mastectomy, they love it when you put a little Veriform in there and show them exactly anatomically where it is. That's your best time to do it, and so really your only time to do it. So I'll give just a little recap about the company Videra that has developed Veriform. They now have 6 years. So I guess you couldn't have done it for 7 years because they have 6 years of clinical experience. We kind of have to keep each other honest. Year. There you go. It's like on your first birthday, you've already lived a year. That's right. But now they have 27,000 patients, or over 27,000 patients who now have Veriform markers in them. There really have been no adverse events, and I think all of us could corroborate that. Other than the palpability,
Probably.
you had to take one out because it was bothering the patient?
I did. I did. It was, yeah. So the lesson learned.
Microphone.
Learned was I had a young woman who had breast implants and had a very thin breast, and so today it's not too surprising to me that 3 years later, since her breast was maybe a centimeter thick, the Veriform, I just wasn't able to bury it enough. It presented itself, and it was a very simple excision, so it is an event, but it wasn't consequential.
And just as an anecdote, I have a patient right now who actually had cancer in extramammary tissue below the inframammary fold, and I put yeah, it was crazy. I put a Veriform in there, and she came back in just right before I came to the meeting, and she's got kind of a little palpable very vague and it's not very superficial, but I actually think it's the Veriform knot. And I'm planning to go back when I get back home to go back to the radiation oncologist and see if I can see that on their planning studies. And if I can, it doesn't bother her enough, I'll have to take it out, but it will reassure all of us that she doesn't have any recurrence going on. So the data is accumulating about Veriform. I think it's really a great product that's very robust and has lots of uses. And once you start using it, I think your radiation oncologist will love you for it. I will warn you that if you don't use it now and you start to put it in, um, caution your radiologist about it because the first few reports that I got after I put it in, I got reports like there's a retained suture material or there's a foreign body. How does this cleaned here? Yeah, or I'm not even using wires. What's going
I'm at Wire and Raytech.
Yeah, so communicate with your radiologist.
Thought before they wrote that they would call me
Yeah.
about it, but they did not.
Yeah, well, communication. What can you say? Anyway, thank you very much. I think we have enough time for Q&A.
Indeed. Thank you. Questions? Yes.
Hi, great presentation, everyone. And I have started using the product. I've used it on 2 patients. So far, they have not yet had their radiation, but I'm excited about the product. Do you document discussion about the Veriform placement in your in your pre-surgical office note? And then do you put it on your consent?
Oh,
Dr. Willie?
I
You seem to be grabbing the microphone.
yeah, it's so heavy. I don't put it on my consent. I never put placement of clips on my consent, so I don't feel that's necessary. Although I do tell patients that I'm going to put this Veriform in to mark the cavity, and that's part of my preoperative consultation. You know, I guess
Dr.
it
Goss?
kind of is the consent, but it's not the formal signed consent.
So because I also got those frantic calls about the retained wire in the breast,
At least I got the call. I just noticed it in the report.
right. No, I got some frantic calls, and we have some snowbirds where I live, so they'll get they'll go to a different destination where they don't know about them. So I feel like it's just mildly helpful to me in my personal documentation when I have them sign that the cavity marker, right? I write partial mastectomy cavity marker, and it's just, yep, I told you about it. You signed, so that's part of why I feel strong about it.
I have to say, I do put it on my consent for a similar reason, and I think I've done too many expert reviews, and maybe I'm a little paranoid about that. That might add to it, and I documented in my op note.
Yeah, I put it in my clinic note that I'm putting a permanent Veriform, so they know it's permanent. I do put it on the consent, but yeah.
I talked to them about it, and then I dictated into my operative note.
You put it in your consent?
I do not put it in my consent, but if you're telling me I should.
No, I don't.
That's where do I am I supposed to be putting it?
I know. I saw your face. You're like, do you put it in your consent? I do, but that doesn't mean that it has to be done.
When I put it on the consent, it's I do partial mastectomy and then I just add it there, but I don't do the whole risks, benefits, alternatives of Veriform. I don't go into that.
No, I just tell patients it's permanent. Dr. Gallagher. Oh, sorry.
Sorry. Yes, good morning. Thank you so much. I am so interested in using this product. But I do have two questions. First is with the combo cases with plastics. Have any of you experienced where the Verifer was cut or disrupted in any way? And the second question is cost. Is there, because, my institution, like most of ours, are probably really into cost effectiveness.
I can answer it. I don't do a lot of cases with plastics, but when I do, I put it in front of them and I tell them this is where I'm putting it, this is where I'd like it to stay in this tissue. If you have to cut across it, let me know and we can adapt to that, right? So if they have to cut across it, which they usually won't, then you can just do a half on each side of it. So there's still a way to mark, just good communication works.
I wrote down the word communicate.
Yeah, one of the things in that setting is, and I found this if you have to go back for a re-excision, because I've had to cut them out for a re-excision, but when we showed where you put like a separate piece on each side, if they have to cut that out, um, that veriform is still in there. And so that note goes over to the pathologist that the veriform is in the old margin. So that's helpful. Um, those veriforms are fairly long, so it's easy to, you still have plenty of leftover to put back in.
The other add-on really quickly is there's never a mystery as to what pedicle, the plastic surgeon is going to use. So they know if they need to cut across wherever you put it and you can adjust how you put it. Like there's never a mystery in any of the plastics.
And
Is that helpful? Yeah.
you, Dr. Clark, you touched on something that I was thinking about. Now, we know in the literature re-excision rates are up to about 20%. I know my esteemed colleagues never have a re-excision rate that high, of course, neither does anyone here. But when we go back for a re-excision, sometimes that cavity is a mystery and it's, oh, I think it's here, especially as we're doing oncoplastics. I think it's here. I think it's here. Does the Viriform placement help you in any way for the rare occasion that you have to go back to the operating room for a re-excision?
Well,
Especially in DCIS, we know that never happens.
once when I had to do that. No, I think it's actually kinda difficult in this day and age. In the old days when we left seromas, it was really easy to open up the old cavity, you know exactly what's anterior, posterior, yeah. But now when we close everything, it's like it's all contracted down, so it's blue, it's a little bit stiff, so it's easy to see or feel, and if you're doing a selective margin re-excision, I leave the old variform in, I take the re-excision specimen, and then I put another variform in the new margin. That's the way I've done it.
Um, yeah, pretty much the same. It's I think also if you so you've outlined that we're closing tissue, but we're also dissecting a distance. So trying to uncover that tumor bed when you don't have the veriform is a much greater challenge, and the veriform gives me great comfort. And
Yeah.
I, when I'm saying to my fellow, "This is the margin," the veriform's kind of backing me up. You're not making this up, Dr. Goss. It's really that's really
I do. I feel much more confident in the rare occasion that I have to go back to the operating room. I am much more confident. I've always said going back for margins is a little bit of voodoo. And this does give me that reassurance. Hey, this is the cavity. This is where I was. I'm very confident that I am taking the correct margin. And yet again, we still don't see any residual disease, but that's a different story.
That's the other thing, and the extent of that margin too, because you don't wanna go back and take a little quarter size margin. You wanna make sure if it's a superior margin, you've taken the whole thing. So I think that the Veriform on that rare occasional, I feel much more confident about that.
I think she'd ask about cost as well.
Notice we did not answer that question. We knew what we were doing up here.
Just wanted to make
It cost booth, go to the booth. Right. Cost is always a difficult question because as you know, every hospital system negotiates and Veriform is always going to be more expensive. When you just look at dollars and cents, I would say Veriform is more expensive than clips, but the advantage of what it does for the comfort of the radiologist, the ability to really do partial breast and target that area is it's that, well, can we measure that? Can we not measure that difference in cost? So I think it's one of those things and my hospital system, it's difficult to get things through, and this was not even I wasn't even called for a question on this, which I was shocked at. I switched, and that's how I think about how long I've been using something. I've been at my current hospital system for about 5.5 years, and I knew I was using it before that. So, if Joe may or may not remember that I had a whole list of things. I was like, "We're gonna have to fight this," and not a question about it. They did see the value in it.
But
But
there
Dr. Gallagher, I
Yeah,
suspect you
no,
had
I
a
did
question.
have a question and a comment. The question is when you are doing these posterior lesions, and you showed wonderfully in your slides, you had exposed rib. If you're needing to put this in the muscle, are you seeing increased inflammation? Are you seeing symptoms like pain? And then my comment is when you're thinking kind of in the future, maybe considering integrating some of the V-lock technology into it so that you don't have these knots might be something worthwhile to look into.
these are so inert that when I counsel the patients about it, I said, "You would never know I put this in unless I tell you, or until you get your mammogram."
Same thing, they don't know that there's clips there, so they don't that's what I tell them. You didn't know that that biopsy clip from your, stereotactic or ultrasound guided biopsy was there, you won't know this is there. Doctor oh,
I just wanted to say when you were talking about there's no difference between whole breast radiation and partial breast radiation. Of course, that's all on the usual metrics of local recurrence and disease-free survival. But there's a huge difference to our patients in their quality of life, right? When they get the whole breast radiation therapy with the entire pectoralis muscle gets radiation, right? That's a different experience, not just in time span, right? It's their quality of life for the rest of their life. And we're the people who are answering these questions, as we've said. And so when you think about that cost and then the patient's quality of life, it kind of goes out for me. Um, when I was
I
doing,
did write that in my into the value committee
right,
because that is something and there are studies to back up the quality of life issues.
um, and then I was just going to say, a different top thought. I kind of lost that one I just had, but I mean, Alloderm. We're throwing Alloderm all around the operating room. We're cutting off thousands of dollars of Alloderm, and we're worried about the cost of this Veriform. And I remember my other thought. So when I was getting it through my institution, because it is more than a WEC clip, there's just no doubt about it. But for an automated clip applier, you're really in the same magnitude of cost. So then when you think about what you get for it, and what I'm going to take home from today is what Dr. Willie said is there's thousands of clips possibly, or maybe tens, in these women's breasts. And so we're asking the radiation oncologist to discriminate between the wing clip over here and the surgical clip over here. And maybe you can on the mammogram, but probably not on the CT. So really it's our responsibility to give them a reliable target. And clips in 2025 probably are not for the reasons I outlined, and then for the reasons that the women have pre-existing clips. So
I mean, I would say my Brad Onk used to call frequently to review with the clips. Well, this clip's over here. Is it still part of the cavity? And with Veriform, those calls have stopped. It's not that we don't communicate. We still do, but in a different way over different issues. Those calls have really stopped because it is so well delineated. Dr.
Yeah.
Clark.
Yeah, so I just switched from a practice model where I worked for just a large private practice that was not affiliated with any hospital system. Now I'm employed by a hospital system with a comprehensive cancer center. And I think a lot of our practices may be going this way, where I'm looking at a whole system based model for my patient. And I'm looking at how many times over their lifetime do they have to go back for additional surgery, additional treatment. When I start looking at things like a Veriform and everything that cost a bunch of money that I'm doing in one surgery, my thing is, what's the cost of this uh, cancer patients' care over their lifetime. And so it's a little different paradigm in how I look at them. So I put something like this in. If I can take them into the OR one time, I can go in there and do 5 days of radiation instead of, 33 fractions or whatever. I'm de-escalating all the care on this patient and I'm reducing the risk that I'm going to have to go back in 5 or 10 years and do another mode of therapy. So it's just a different mindset. And I think as reimbursements get cut and we know that we don't have unlimited funds to pay for people for the rest of their lives. So I start looking at the cost of individual things a lot differently.
I just wanna I know some people who have just gotten Veriform into their institutions and have fought the battle, but does anybody have any words of advice to those who are kind of trying to get it in? Were there any magic words that you said that got you going? And Ian knows that I'm targeting him.
Yeah, just like you will mention, I recently went through that value analysis committee and so much other party, although that shit, there's very little pushback because it was recognized. And this actually helps beforehand to talk to your liaison caucus, you get them on the board and speak to, the members of the value analysis committee. That was the thing I think really helped push it through because they saw multiple clinicians were using it. They're going to have downstream effects to reduce the number of practice of radiation and for patient satisfaction. So I think that was
The treatment planning also takes them a shorter time because it's easier for them to figure out. So now what's very expensive is physicians' times, especially radiation oncologists. And if it can decrease the amount of time that they have to spend on treatment planning, that helps. Yes.
I told him it's a hospital reimbursement code. How many told?
Joe?
Yeah, there's a HCPCS, the C9728 facility reimbursement that well covers it.
I think we're close the way they use it.
It does.
Right. So it becomes what we call a pass through that we do not, to my knowledge, have a code for putting it in, but the hospital does get reimbursed for the cost of it, which does help get it through value committees. Yes, there's a question.
I was just curious. You guys showed nice pictures of mammograms and such, but how does this show up on an MR? I don't have a.
So
I
there's
don't have a picture of.
I don't have a
it's
picture.
completely
Sandra, you always come up with those kinds of questions.
it should not show up. It's completely polymeric. There's no metal.
I don't think I've ever.
Right. There's no blue. That's why I'm hesitating because I don't recall ever seeing it on an MRI, which means it must not show.
In almost 7 years.
Yeah, almost 7 years.
No,
No,
not at all.
no,
It's
not at all.
hard, it looks like.
Yes.
Have you found, do any of you operate at most like outpatient centers that are not affiliated with your systems? Trying to get, is it harder to get the smaller places to agree to the increased cost? Because they don't have a facility fee they get billed. So have you had, are you going to get all the patients you take care of or just at places that are hospital?
Not sure if everyone can
No,
hear that question. Do you want to repeat the question as you answer?
Yeah, so the question was if you're operating at a hospital system or outpatient surgery center, something like that, that's not affiliated, say, with your institution, was it more of a problem to get them to bring it on board? And that actually for 8 years was my situation, and I did not have a problem. Whatever I wanted to bring in, they would just bill it back out to the patient. So I didn't have a problem at all.
Right, and that's part of it is that it's not bundled in the OR fee. There is a code for that specific, for the Veriform itself. So the ambulatory care center or whatever, the ASC, can bill for that. So they have to pay for it to start with, but it gets reimbursed to them.
Also, I just thought of this. If any of you are in Epic, this goes in as a implantable device. That's what in our institution. So you can really track all of your Veriforms if you want to. That's one of the ways we did our
They
study.
don't bill it as surgeons that way. Just to be
No, you don't
right,
bill
I
it that
just
way, but it's
being clear on that.
exactly.
There have been
nurses-
instances for companies in the past.
That's
Let's
true.
not confuse the two.
That's true. But the nurses put it in as an implantable device because it's permanent, and it shows up under that category. So if you ever wanted to track all your patients, you can easily do that, at least in Epic.
Any other questions? I just want to be respectful that the general session is starting in under 10 minutes. I see Dr. Farr looking at me like, okay, everyone's got to get there. All right. Thank you all so much. We are here if you have any other questions, or feel free to reach out to us at any time. But thank you very much.